Hello, this is Dr. Shannon Da Silva, and in this presentation we will be going over ultrasound antepartum testing. So let's start with indications for outpatient antepartum fetal testing. So we call this antepartum fetal surveillance, we may call it APT, antepartum testing, but what is it and when is it indicated? And when is it initiated and how is it done? We need to know all of these things as you begin interpartum, antepartum, even your residency courses. You need to, in high risk, you need to know what it is you're ordering, why you're ordering it, what it is exactly, and how it's done. Many patients will ask questions about it, so you need to be ready to answer. So some of the things we're going to be covering is a BPP, an NST, a CST, and MCA and UA Dopplers. The primary goal of antepartum fetal surveillance or antepartum testing with an NST or contraction stress test is to identify fetuses that are at risk for hypoxic injury or death. And we want to be able to intervene urgently and appropriately to prevent these adverse outcomes. So that's why we often don't start antepartum testing really early, because often, even if we were to get an abnormal result, we probably, we most likely, or in most cases, would not deliver early. So when we talk about antepartum testing, why do we do this? So a normal antepartum test is highly reassuring of the fetal well-being. These tests can have a very low false negative rate, meaning the chance of stillbirth within a week of a normal result is very rare. So when we talk about negative predictive value for an NST, it's about 99.8% that the baby will not have a stillbirth. And for a CST, a BPP, or a modified BPP, your risk, the negative predictive value is actually greater than 99.9%. So testing is performed more frequently with pregnancies that are at even more increased risk. However, it's important to remember that this does not predict acute changes such as like a placental abruption or umbilical cord accident. So just again, the negative predictive value is the likelihood that a fetus will remain healthy, so not experiences stillbirth, within a defined period of time after the normal antepartum test. And most often it's about a week. In other words, if the test is normal, then we can confidently say that adverse outcomes like a stillbirth will not occur in the near future. So that is why when we have a patient that is high risk, or maybe they maybe the patient is obese, so they might want to do antepartum testing once a week. But if they're obese, plus they have chronic high blood pressure, plus they have diabetes, then they would likely want to do it several times a week. So usually it's about twice a week. So it's important to know why we are doing those tests, but also to remember that this doesn't prevent or predict acute adverse changes like a placental abruption or a cord accident. So when do we start these? So when we are discussing or trying to decide when to start antepartum testing, it's important to consider the prognosis for neonatal survival. So if you are doing it at 24 weeks, the rate, the chance of the survival is much lower than at 32 weeks. The risk of fetal death, the severity of the maternal disease, the potential for iatrogenic prematurity consequences. So again, like if you deliver really, really early, and then complications from a false positive test. So, we talk about, especially midwifery, we don't want to over test because what do we do with information if it is abnormal? So we want to make sure that that's valuable information. So ACOG suggests starting at 32 weeks or later, and maybe earlier if it's really high risk, such as like a chronic hypertension patient that has that with IUGR, because that's telling us that something more is happening. So again, how often do we do the test? If the indication for testing is not persistent, then the repeat is not needed. So these cases would be like decreased fetal movement. So the patient comes in, she reports decreased fetal movement. You listen by Doppler, and you also want to get fetal antepartum testing, because just listening one time to heart rate doesn't give us the full picture. So that could go away, the baby starts moving, and we're fine. Another thing is, so if the condition is persistent, then they need to be periodically monitored until delivered. So if they're stable weekly, so this could be a patient with diabetes where the baby's growth is normal and they're well controlled. If they're unstable or worrisome, twice weekly. And then if there's any significant change, then we would want to do it at that time. Even if they just had one, we'd repeat it. So the growth should not be done more frequently than every 2 weeks because of inherent error. And so we want to not do those more often than 2 weeks. So what if it's abnormal? I know a lot of times transitioning from a nurse to a provider, we're used to just charting down what we see, but at this point we need to start thinking, okay, now what do I do about it? And so the concern is when we have a false positive rate, they can more often have a false positive rate. It doesn't have a high predictive value in that case. And so the general principle in that case is to do another test. So let's say a patient comes in. One of the way we monitor fetal well-being is decreased fetal movement. So if she comes into your clinic and she's telling you the baby is not moving very well, or she calls your clinic, the next step would be to do another test. So you do an NST, a BPP is most often what we would do. Let's say that now you do the NST and it's not reactive. So we can't just send her home. We can do extended fetal surveillance. That's where you send her to the hospital for several hours to watch the baby. A CST, contraction stress test, that's rarely done anymore. Or you can move on to a BPP. If there is an abnormal test, most often we would want to follow up again in a closer time period, and you would need to notify your collaborating physician in that case, or I would recommend you do. So all of these you likely know, but a non-stress test is reactive when the gestation is greater than or equal to 32 weeks, and there's 2 accelerations with an increase of 15 beats per minute above baseline that lasts 15 seconds with a return to baseline. So that 15 by 15, and we would need a 20-minute period. This would have to happen within a 20-minute period. So I've worked with MFMs, and they're like, you don't need to have the full 20 minutes if you already have 2 accelerations. So you can take them off when they have 2 accelerations, but you would need to go with your practice at that point. If they're less than 32 weeks, we say 2 accelerations with a 10 beat per minute above baseline with a duration of 10 seconds. So a 10 by 10. Of course, you would need to know the baseline to be able to determine this. So let's talk about deceleration. So we have sometimes during an NST, you see a variable, you might see a late. If there's contractions, you might see a prolonged deceleration during APT. So this would require further evaluation. In most cases where I have worked with the Adam Maternal Fetal Medicine office, we send the patient in for extended fetal heart rate monitoring. And then again, the next thing would be to do other testing. So a BPP, looking at Dopplers, umbilical Dopplers, umbilical artery Dopplers, looking at the AFI. But management really should be guided by the results of additional evaluations. So if the baby's already 37 weeks, likely we would just deliver the baby. So here's an example of a reactive NST or non-stress test. So again, if we have a non-reactive non-stress test or NST, this usually warrants further evaluation. Some options include repeating the test in 30 minutes, vibroacoustic stimulation to elicit accelerations. That is okay to do. Perform an additional test or a backup test And then if possible, modifying risk factors. So if the patient is smoking, to tell them not to smoke prior to the test, or make sure that they're not taking medications that could cause sedation to the fetus. So a contraction stress test is not as often used as an NST because it's less convenient to perform. You have to have oxytocin or nipple stimulation until you have 3 contractions in a 10-minute period. When we interpret, the CST is interpreted either as positive, which positive in this case is abnormal. So contraction stress test, or CST, is rarely used today because it's less convenient than an NST. I haven't seen one actually used in my practice outside of just an induction, an induction of labor situation. It does require oxytocin and nipple stimulation, where we need to achieve 3 or more contractions in a 10-minute period for the test to be done. So as we interpret it, if it is a negative test, that is normal. So as opposed to a not NST, if it's reactive or positive, that's a good thing. If it's negative here, then that's a good thing. So just keep that in mind. So there would be no late decelerations or significant variable decelerations. So a positive or abnormal test would be if there is a late deceleration that occurs after greater than or equal to 50% of contractions, even if there's fewer than 3 contractions in 10 minutes. Equivocal interpretation, if there's a suspicious intermittent late or a significant variable deceleration, if there is tachysystolic decelerations with contractions occurring more often than 2 minutes, so the patient has too many contractions and that's causing decelerations, or if there can be an unsatisfactory test where you are not able to achieve the 3 contractions in 10 minutes. And so then you cannot come up with a result. So significant variables would be described according, so again, this is not done as often. So during labor, a significant variable deceleration may be defined as lasting greater than 60 seconds and dropping greater than 60 beats per minute below baseline, or lasting greater than 60 seconds with a nadir less than 60 beats per minute, regardless of baseline. The ACOG or NICHD has not provided a standardized definition for significant variables in the context of a CST. So let's talk about MCA Dopplers. This may be unfamiliar to some of you, or maybe many of you. The middle cerebral artery Doppler is known as the MCA peak systolic velocity, is a good non-invasive measure of fetal anemia. With fetal anemia and possible hypoxia, the velocity of the blood flow to the fetal brain increases. The MCA, or the peak systolic velocity, is if it's greater than 1.5 multiples of median, or MOM. This is a high risk that the baby has anemia. The false positive rate of this measurement is about 10%, and it increases after 35 weeks of gestation. And other things can impact a false positive result, like caffeine consumption, fetal movement, things like that. So let's talk about a peak systolic velocity. So the peak systolic velocity is the fastest speed of blood flow during the systolic phase of the cardiac cycle. So this is when the heart contracts and pumps the blood forward. So how is it measured? So the Doppler ultrasound, the machine detects the movement of the red blood cells in the vessel. The highest point on the waveform is the peak of the systole. So this is the peak systolic velocity. So you can see on this image, there is a wave and there is a peak in the wave. So the middle cerebral artery, the peak systolic velocity reflects how quickly the blood flows into the fetal brain. So anemia, the blood becomes thinner and less viscous, and the heart compensates by pumping faster and harder, causing the blood to flow at a higher velocity. So the MCA, or the MCA peak systolic velocity, or PSV, is a reliable, non-invasive test for fetal anemia. So how do you think that they would determine fetal anemia outside of this? So before they could collect blood from the fetal umbilical vein, which would have to be done through the mother's womb, which obviously is a much higher risk than this test. And another test that they can do is, depending on what is happening, so if anemia is caused by isoimmunization or like RH incompatibility, then that causes a breakdown of the fetal blood, and that can cause higher bilirubin levels, and they can actually test it through the amniotic fluid, which again would require an amniocentesis. And so, but the other causes for fetal anemia, like a twin-to-twin transfusion, or different maternal illnesses like parvovirus can cause fetal anemia. Those cannot be tested through the amniocentesis, just pulling out fetal amniotic fluid. So the only way that they could determine in that case is through either watching for hydrops, which at that point it's too late because the fetal anemia has caused complications, or by actually drawing blood from the baby's umbilical cord, which is much higher risk. So this is a good test, and we're very thankful for it. It is not perfect, but it is a very good test because it can identify fetal anemia much earlier than looking for signs of hydrops. So the MCA multiples of median. So this is very confusing. It's something that we talk about the MOM in different places as we talk about antepartum care. So in this setting, the fetal Doppler values, like the MCA peak systolic velocity, or PSV, normally change with gestation. So when you look at a baby that's 28 weeks versus a baby that's 32 weeks, it's going to be different. And so to help facilitate interpretation, each value is compared to the median average expected value for that specific gestational age. So the patient's result is expressed as a ratio. So the MOM is where we put the patient's MCA PSV, so what you get in the result, what the usually sonographer measures, and then they divide that out of the median MCA PSV for that gestational age. And so then that gives you an MOM. And so if the expected median of the PSV at 28 weeks is 40, and the fetus, the baby you're looking at, is 60, so that's higher than 40, then the MOM is 60 divided by 40, which is 1.5. So it is higher. So when we have an MOM of 1.5, the clinical interpretation of the MOM of 1.5, it strongly suggests fetal anemia. So this helps the clinicians, the providers, the MFM, identify a fetus at risk for alloimmunization, parvovirus infection, and other causes of anemia. So twin-to-twin transfusion could be a cause. Fetal false positives do increase, like I mentioned before. So a good way to say this is the MOM is how many times higher than the normal average at this gestational age the baby's blood flow velocity is. Okay, so moving on to umbilical Doppler arteries. Probably most of you have heard of this, if not all of you. So umbilical artery Dopplers, just a reminder that umbilical artery blood flows from the fetus to the placenta. So this reflects the utero-placental resistance or perfusion, so how well the blood is getting through the placenta. So clinical indications, monitoring the placental, so anytime we need to monitor placental insufficiency like IUGR, preeclampsia, or decreased fetal movement, or a non-reactive NST. Any of those situations, we would want to make sure that the placenta is still functioning well. So these images, so you can see here, this one of the images is showing the actual measurement of the umbilical artery Doppler. And then the middle one is showing the different calculations that they use. And then the one on the other side is showing the calculation, just how they're looking at the red blood cells. So they're measuring the actual movement of the red blood cells, just like the MCA Dopplers were. So just again, more review of umbilical arteries. So remember, it carries deoxygenated, nutrient-depleted blood flow from the fetus to the placenta. So factors that affect placental resistance are sometimes normal, like gestational age. It can be impacted by placental location, pregnancy complications, or maternal disease like chronic hypertension. So if you look in the image, you can see the umbilical arteries are outlined in the red box, and you can see the purple arrows are showing the flow from the baby. So the baby is represented as the organs and the heart and the lungs over on the side, to the placenta. So they're going from the baby to the placenta, and it's oxygen poor blood. So when we're talking about UA Dopplers, there's the umbilical cord is long, and so there's a fetal end, there's a loop in between, and then there's the placental end. And so where you measures does matter. And so the fetal end, the end near the baby, tends to have the highest resistance. So the blood is leaving the fetus. Changes in resistance of placental disease appear here first. So this may be monitored to look for early placental sufficiency, but this is not typically where we would monitor the UA Dopplers. So then we have the free loop, or so this would be like a mid-cord, or we would want to find it floating in the amniotic fluid. And this shows the average resistance between the fetus and the placental ends. This is the best practice, the most acceptable and commonly used place for consistency. The other end, the placenta end, is where the cord inserts into the placenta. So this is going to have the lowest resistance since the blood is about to enter the placenta, and it may mask early abnormalities and making pathology harder to detect. And this site often underestimates the risk to the baby, or the pathology to the baby. So I have a picture of a hose. So if you think about the hose and how blood or water would flow through a hose with filters at the end. So closest to the source, or the fetal end, is where most pressure is needed. So right where the valve is, that's where it's going to have higher pressure. And then closer to the filter, or the placental end, the pressure has already dissipated some. And so that's going to have lower resistance. So if you think about this hose, the pressure is going to be hardest right when it comes out and lowest at the end. So the UA Doppler waveform. So a normal waveform is going to show a sawtooth pattern. And this tells us that the blood is flowing forward toward the placenta. An abnormal waveform may be because of absent diastolic flow or reversed diastolic flow. That can be due to severe placental resistance, where the blood is not able to flow through there and it's actually pushing back. Sometimes you may read literature and they talk about umbilical Doppler, artery Doppler indices. And so when you get a sono report back, you may see different things. You might see SD ratio, you might see resistance, you might see ratio index, you might see placenta index. And so this is reported in the ultrasound to describe the placental resistance. You can see the different calculations to find this. And so generally, most of the times, they'll have a qualitative interpretation below that to where it says normal forward diastolic flow or normal umbilical artery Dopplers, or it might say decreased diastolic flow, absent in diastolic flow, or reversed in diastolic flow. Again, a lot of times if you're doing these patients are with the maternal fetal medicine specialist, and so you don't have to worry about it. But if you do get a report back and it's not normal, then I do recommend that you consult with either the MFM or your collaborating OB-GYN. So the RI is the resistance index, and then the PI, is the pulsatility index. And so this represents the entire cardiac cycle. So it gives you a more complete measure. And like I said, you may see one or all of these in a sono report. The big thing is that a normal placenta will have low resistance because the blood should flow really well through it. And so that would have a good diastolic flow and low indices. If you see high indices, that means that there's a problem. And there's poor diastolic flow and high resistance. So when we talk about umbilical artery impedance or placental perfusion, normal pregnancy with advancing gestation, placental vessels remodeling and dilate, this allows low resistance and continuous forward diastolic flow. So this impedance index decreases as pregnancy progresses. With uteroplacental insufficiency or IUGR, preeclampsia, things that cause problems with that, the placental villus vasculature is already abnormal and is a high resistance state. So less blood flow gets through in diastole, and this results in absent, decreased, or reversed in diastolic flow. And so that causes the indices to become elevated. This is very complicated and kind of a difficult concept to understand. So I just recommend that you think through it and review and listen to this, read this information in your book so you can understand what you're looking at, because we don't want to order a test and not know what it is and what we're doing with it and what to do with the result and how to explain it to the patient. So a little test. Okay, so let's look through these and remember what the umbilical artery Doppler should look like. So we're going to look at which one is normal, which one's absent, and which one is reversed. So A is normal, B is absent, and C is reverse. So again, reverse is the worst. That represents severe uteroplacental issues, and that would need to be intervened. So it is important that you know the NIC HD definitions of fetal heart rate characteristics. All of you will have to take a competency on this before you go to an Antepartum, but it's good to be able to identify the variability, fetal heart rate, baseline rate, what's normal, what's abnormal, accelerations, decelerations, late, variable, early, and prolonged. We will talk about a biophysical profile. It's important that you know how to identify, and you will have to learn in this course how to calculate it. So I'm not going to go into all of this, but this is looking at the non-stress test, fetal breathing movements, fetal tone, the amniotic fluid volume, and fetal movement. And you will determine a biophysical profile result, and depending on what that test is will indicate a level of concern. So if they only get 2 points or they get no points, you can't give a patient 1 point for any of these criteria. Testing can begin as early as 24 weeks. but the observational data shows that the rate of stillbirth with a non-fetal growth restricted baby rises between 32 to 34 weeks to term. And so that's why ACOG recommends in most cases to start at 32 weeks. It is either done weekly or twice weekly. So according to ACOG, a BPP of 6 is equivocal. If they're already 37 weeks, we recommend delivery. If they're less than 37 weeks, usually we'll repeat it in 24 hours. If the BPP is a 4, then we recommend, ACOG usually recommends delivery if they're over 32 weeks, and it just will depend on the situation if they're under 32 weeks. If the BPP is less than 4, in pretty much all cases, we recommend delivery. And then if there's isolated oligohydramnios, that is very concerning, and it is its own criteria, and it is recommended to deliver after 36 to 37 weeks or at diagnosis if it is later. If it is persistent oligohydramnios, which is low fluid. All right, so fetal imaging, we're going to go over these. So when we talk about fetal imaging, we'll throw around terms like limited ultrasound, anatomy scan, detailed ultrasound, fetal echo. So I'm not going to go through a comprehensive information about this, but just so that you can kind of know what's the difference between what you're ordering and what's being done. So a limited ultrasound, I talked about this in another of the presentations, is performed to address a specific focused question when an immediate impact on management is anticipated. And so this is what we as certified nurse midwives can become certified in if you wanted to pursue that. So this, we look at the presence and size and number of gestational sacs. We look at, is there presence or an absence of fetal cardiac activity or the fetal heart rate, checking for presentation, measuring cervical length, like in the cases of threatened preterm labor or history of preterm labor, and then AFI with the NST or doing a biophysical profile. So the AFI is this deepest vertical pocket in each 4 quadrants. It is important to not measure through the umbilical cord because this falsely elevates the measurement. So you want to make sure that you are not getting an umbilical cord in your image. It is important to measure in a longitudinal plane, and the transducers should be perpendicular to the floor. So I have seen many people do this incorrectly that are not sonographers, and so I really hope that you guys take this in and you do things correctly. So a standard ultrasound, or also known as the anatomy scan, I'm not going to go through all of what it looks at, but it does do a considerable more of fetal evaluation than the limited ultrasound, looking at the different fetal anatomy, fetal movement, looking at maternal anatomy, placental appearance, cardiac activity, presentation, and biometry. So biometry means measurement. So that's how we know how big the baby is, the gestational age, fetal weight, things like that. So these are just all of the lovely images of the standard anatomy scan. Many sonographers are very particular because they're trained to get a certain image where they're looking at the landmarks of the baby's body to make sure that they're getting the right measurement. Because if you just are off a little, that can make the measurement very different. They also have to get certain images to show documentation that what they're finding is truly there. So then we have the targeted or detailed ultrasound. So this is like a level up from a standard ultrasound or anatomy scan. So this may be indicated if there's a previous pregnancy where a fetus has a anatomic or chromosomal abnormality, fetal growth restriction, a pregnancy with a complication like congenital infection. A fetal evaluation may be is needed for a more detailed examination. So maybe they see something, but they need a higher level of ultrasound. So this is typically performed in an MFM clinic with extra training for the sonographers. So it looks very specifically at all of these organs. I'm not going to read it again, but it's looking much more detailed than just the standard ultrasound. So the last thing we'll talk about with different ultrasound is the fetal echocardiography. And so this is done when either a prior baby had a history of a cardiac disease, or the maternal history or family history has a concern for congenital cardiovascular disease. Some cases, like a patient who is a pre-existing diabetic patient that was uncontrolled, leading to risk of malformations during that period of time where the risk is higher for the baby. So those would likely have to have a fetal echo. And so this can be performed at an MFM office, but not all MFM offices have sonographers that are trained in this. So sometimes neonatology practice will have their own sonographer to do this, or the neonatologist could do this sono. So, for example, I work at the county hospital, and I worked with the maternal fetal medicine specialty clinic for several years, and we actually did not have sonographers that were trained in this. And so we would send our patients that needed this test to the children's hospital in our area, and that they would actually have a visit with the neonatologist and have a sonographer do their sono there, and then the neonatologist would do another look at the ultrasound. So this is just showing some of the imaging from those ultrasounds. And that's it.